Mayo Clinic presents the Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.
Everyone, thanks for your patience. I'm really excited for this. I get to introduce my friend and the wonderful leader in the business of healthcare, Dr. Schupbach. Dr. Schupbach is an assistant professor of emergency medicine here at Mayo Clinic in Rochester, Minnesota. He's a graduate of our residency program here, as well as the Mayo Clinic Alex School of Medicine. Along with that, he received his Master's of Business Administration, or MBA, from Harvard Business School, where he worked under the mentorship of Professor Clayton Christensen and focused on disruptive innovation in healthcare. He received his Bachelor's of Science in Mechanical Engineering with a minors in Aerospace Engineering and Architecture from Washington University in St. Louis. He's also an amazing photographer, and a lot of the pictures and imagery that you see in our educational work and our PowerPoints come from John. Originally from Colorado and Arizona, Schupbach has spent several years living and working abroad, including in Paris, France, New Delhi, India, Shanghai, China, and other places. He is also the founder and CEO of Squalor to Scholar, an amazing nonprofit organization that provides K through 12 vocational and university education and support services to gifted children and young adults that get overlooked and undersupported throughout India. He's touched on this work in his senior resident grand rounds, and it was truly an outstanding and memorable talk that I think about even years later. And if you want to hear it, you can revisit that talk on Always on EM, the podcast, season 1. He melded that experience with Squalor to Scholar with his interest in healthcare, which is to say that he's developing new business models and new markets to simplify how people pay for care and understand where money is going that impacts the care delivery in order to simplify what we provide. Today's Grand Rounds, I'm sure, is going to be equally thought-provoking and memorable, and I'm really excited and grateful. Thank you so much, John, for doing this.
Thank you so much, Venk, for the kind intro. Thank you all for coming today. It's an honor, and I'm just going to jump right in. I want to start our discussion with an actual case that occurred here at Mayo Clinic. And I want you to imagine for a second that you're the parent of a young child. They're playing on the swing sets on a Friday evening, and one of the older siblings pushes your youngest son onto the ground, and he sustains an injury to the forearm. You do the rational thing because it's Friday afternoon, and you bring them to the St. Mary's Emergency Department, where they're cared for excellently in our pediatric ED. And that's what occurred in this case. The patient had x-rays obtained, and they revealed a non-displaced distal radius buccal fracture, and a Velcro Royce splint was administered, and the patient was discharged home. How do you feel about this care? If you were to receive a survey as the parent, how do you think you would rate your experience? Was it efficient? Was it effective? Was it timely? Was it high quality? Now imagine 6 weeks later, you receive 3 pages of bills from Mayo Clinic. These are the actual screenshots of the bill to this patient's family. On the left here, you can see various professional fees. The professional fee for the level 4 visit of $684. The professional fee for the placement of the Velcro splint, $1,400. The facility fee for the visit, $1,500. The facility fee for the placement of the splint, $1,200. The fee for obtaining the scans, $349. And the fee for reading the scans, approximately $100 combined. All convoluted, all listed in detail, for a total cost of more than $5,246. With out-of-pocket expenses, approximately $4,000. Now, how do you feel? Does this feel like a fair price? Does it seem too expensive? If it seems unfair, who's to blame? Do you feel antagonistically toward Mayo, or do you feel antagonistically toward your insurer, Blue Cross Blue Shield in this case? For typical products, I want to talk about pricing. Typically, a customer has a certain willingness to pay for a product. That's this white box here. And as a business, when you create that product, you've created that value because that customer is willing to pay that amount. You have a certain cost to deliver that product. And then the price that you charge and what the customer ultimately pays is the value. Essentially, the difference between that price and the cost is the value that you capture. In this scenario that I've just described, we have a customer's willingness to pay for care. We don't know what that is, but they came into the emergency department because they needed care of a concern for a broken arm. We created value in that instance. We had a cost to deliver that care, but where people feel anger and frustration is the price of what the customer ultimately is presented with often far exceeds their sensation of what their willingness to pay was. When the value captured exceeds the sense of what the customer felt that the value was created, that's the sensation of unfairness in the pricing of American healthcare. The variability in pricing across healthcare is vast. So this is a really interesting whisker plot of commercial and Medicare price variation for outpatient procedures by CPT code, or current procedural terminology. And so if we look on the right side here, we see the emergency department billing codes for level 4 and level 5 visits. And you can see here, the box contains the 25th percentile to the 75th percentile of what is charged across all emergency departments for those level 5 visits. And so they range very substantially. And you can see here, this is the end of the whisker is the 10th percentile to the bottom, and at the top, the 90th percentile. So a level 5 visit can range from, on the low end, $486 to, on the high end, $3,549, depending on where you go and depending on what kind of insurance that you have. In the 2000s, there was an outcry about lack of insurance. And so the Affordable Care Act under the Obama administration address this by mandating insurance and really changing how insurance is purchased in the United States. And we had a resultant increase in the share of Americans who had health insurance. But today, people have still felt burned by the healthcare system, and there's an ongoing fear of the cost of obtaining medical care. So 27% of people in America forego care in a given year, in this case 2023, because they were afraid of the cost of it. Last month, I'm sure all of us are aware of this incident in New York City. A Minnesota man working in healthcare was attending a conference in New York City, and he was ruthlessly murdered, shot from behind by an aggrieved and angry patient of the United States healthcare system. The reaction in the media and online it really took the media by storm. And I think a lot of people were shocked by the amount of support and kind of rationalizing this heinous act. This is the manifesto that man left. His name was Luigi Mangione. And he wrote this in just a very brief letter that was left as his manifesto, essentially. That a reminder, the US has the #1 most expensive healthcare system in the world, yet we rank roughly number 42 in life expectancy. United, speaking about the healthcare insurance company that the man was the chief executive officer of, is it's not quite legible, largest company in the US by market cap, behind only Apple, Google, and Walmart. That's not exactly true, but it's stated here. It has grown and grown, but has our life expectancy? No. The reality is, these indecipherable words have simply gotten too powerful, and they continue to abuse our country for immense profit because the American public has allowed them to get away with it. Obviously, the problem is more complex, but I do not have the space, and frankly, I do not pretend to be the most qualified person to lay out the full argument. But many have illuminated the corruption and greed decades ago, and the problems simply remain. It is not an issue of awareness at this point, but clearly power games at play. Evidently, I'm not the first to face it with such brutal honesty. As someone who's worked really hard to make a positive impact in our healthcare system, I think it's really sad to read these words and to see the state of public discourse that we've come to in American healthcare, and that people are resorting to these measures. It's not hard, though, to see why people are angry. The cumulative increase in premiums over the last 10 years has continued to, premiums and deductibles have continued to outpace workers' earnings and inflation, taking a bigger and bigger bite of employees and everybody's total compensation. The annual healthcare spending per person in the United States is now approximately $15,000 per year and growing. The total premiums paid for an employee's health insurance for family coverage is now $24,000 a year. About $17,000, $18,000 of that coming from employers, and then $6,500 coming from workers. But at the end of the day, it's all coming from the workers because you're getting this from your employer. This is money that you've earned, and this is money that would have been paid to you if it weren't for needing to go to health insurance. So this is money you've earned, and this is often, I think, overlooked in many public conversations. And again, this is outpacing the rate of increase in household income. So the fact that the median household income now is about $80,000, you could think of that as another $20,000 on top of that. So $100,000 really is the total compensation if you're just looking at healthcare expenses, not including retirement benefits. And we're an outlier among the world. This is not new knowledge. 17.8% of our entire gross domestic product is spent on healthcare, far outpacing other countries. This regression of healthcare spending per capita to GDP per capita kind of blatantly shows how far outside of an outlier we are. So how are people covered by health insurance in the United States? I think most useful to break it down by age ranges. So for most people in the 19 to 64-year-old group, 11% of those people are uninsured. 73% are covered by private insurance. 63% have employment-based health insurance, which we'll go over in a minute. And then the rest either direct purchase or TRICARE, which is a military mechanism. About 16% of that age group have Medicaid. When you look at the 65 and older population, a very small percentage of them are uninsured. Some have employer-based private insurance, but the vast majority have Medicare. 93.7% of people 65 and older have Medicare. And then again, 7% have Medicaid. And some are dual enrollees. And then 18 and under are typically covered by their parents' employer-based insurance if they have the means for that. Otherwise, they're covered by Medicaid in most instances. Looking at the employer-sponsored health insurance model so that we're all on the same page. A patient works for an employer, you get wages in return. The employer pays a third-party insurer's premiums. The patient also pays a portion of the premiums. And then as a result, the third-party insurer gives risk coverage to the patient. So when you go to seek care, you pay copay or insurance or some other share of the cost, and the healthcare provider submits claims to get reimbursement from the third-party insurer. So this, in essence, in the United States healthcare system, is the simplest version of how things can possibly work. People spoke about this anger of the insurance system a long time ago. It's been ongoing. They say, well, health insurance companies shouldn't profit that much. It's not fair. We need to regulate it. Legislators listened, and in 2012, the Affordable Care Act implemented profit capping for health insurance companies, stating that 80 to 85% of all premium dollars brought in to the insurance company must be spent out as either services or administration. And so if we look at that another way, imagine you're in the insurance company, you get all of the revenue coming in from premiums over the year, and the amount that you have to spend on medical services and administration has to be 85% or more. You can only have a 15% profit. Now sit here and think for a second. If profit's capped at 15% of your total revenue, how can you increase profit? You can't decrease the amount you spend on medical services by keeping revenue constant. The only way is to increase revenue. You have to increase revenue. And the only way, and you can't increase revenue and keep this at 85% without increasing the amount that you spend on medical services administration. Your incentives are for costs to go up. Either that, or you have to recruit more patients. And so that we're seeing both things happen. So this is a map and a list of states by how many insurers there are with greater than 5% market share. If we look at Alabama on the first line here, there's one insurer with more than 5% market share. And that insurer has 95% of the insurance market in Alabama. And so you can see across this entire column, there typically aren't more than 2, 3, sometimes 4 to 5, but a very small number of health insurers with any kind of market dominance in most states. And so this is aligned with the last slide of the only way to grow is either to increase costs to increase revenue or gain more market share. And so you gain more market share by buying out your competitors or just out competing in the market. But once you're done, and you can see there that there's a lot of consolidation that's occurred. So then the next way to grow profit is to start buying adjacent businesses. And so that's something called vertical integration. If you're a health insurance company and you buy another health insurance company, that's horizontal integration. But if you're a health insurance company and you start to buy pharmacies and maybe urgent care clinics, that's vertical integration. And so that's what's occurring across the industry with different companies like Optum buying different pharmacies, primary care operations. CVS is doing the same thing. They bought MinuteClinic and Signify and Renal Care. Walgreens is buying VillageMD and CareCentrix. Amazon bought One Medical and bought PillPack. And so each of these are growing verticals because they're now constrained so much in how much they can grow horizontally. This is an example from United Health's website of just the provider practices that they've been buying up across the nation. United Health Group now employs or is affiliated with 10% of all physicians in the United States. I think that's just remarkable. So 90,000 physicians are either employed or directly affiliated with United Healthcare. So in trying to reduce the profits of the health insurance companies, we actually incentivize prices to go up, for consolidation to occur, for market competition to really decrease because the number of insurers has decreased, and leading to vertical integration and the buying up of the entire healthcare vertical. So let's instead look at where the $4.9 trillion that's spent in America goes every year. The majority, 31.2%, or the biggest chunk of that, I should say, goes to hospitals, with the second largest, 20.1%, going to physicians and clinics. Retail prescription drugs get a lot of publicity, but they only account for about 9.2% of the overall healthcare spending. The vast majority is toward us, hospitals, physicians, and clinics. But on a per capita basis, inpatient admissions have been declining over time, even before the pandemic. Emergency department visits, although they get a lot of press, are pretty stable. They decreased a little bit during the pandemic, which we were all aware of, and they've kind of rebounded, but are about where they were pre-pandemic. But the prices of the care themselves, for many of the reasons that we just discussed, continue to go up, outpacing inflation. And the sector of the healthcare industry where prices are increasing the most in the past year are actually in the hospital space, with hospital prices increasing at almost 7%. So there's been push over the last few years toward price transparency, and representatives listened, and they implemented in 2021 the hospital price transparency rule. This requires that all hospitals be required to provide clear, accessible pricing information online about the items and services they provide in two ways: as a comprehensive machine-readable file with all the items and services, and in a display of shoppable services in a consumer-friendly format. So Mayo Clinic has complied like everyone else, or as they should. This is one example of the Minnesota Primary Care Price Transparency Form that you can find easily on our website. And it shows, let's look here at 99205. It's a new patient office or other outpatient visit, level 5. And the clinic, we charge $621 for that. Medicare reimburses $211, and the average commercial insurance payment is $489. Helpful, but as it says down here, your health insurance company has likely negotiated discount or contracted rate for each service. Your health insurance company's negotiated price might be higher or lower than the average commercial payment amount listed above. Useful information. I don't know how many patients actually use this. It's interesting nonetheless. You can also go on the website and get that machine readable file that I mentioned. And I did that the other day, and it's a 1.27 gigabyte file for Mayo Clinic Rochester with 1 million rows of data. So there are databases now. Turquoise Health is a new company that started up to consolidate all of this price transparency data. And so this is similar to the whisker plot that we looked at before. This 247 is a DRG, which is a Diagnose Resource Group, I believe it's called. That's basically kind of a payment for a certain episode of care that kind of gets all lumped in together. And this 247 is the code for a percutaneous drug-eluting stent. So the median price is $26,000. At the lower end, 10th percentile, it's $12,000. The high end, 90th percentile, it's $49,000. So all this kind of data is coming from this price transparency information. But the question is, if insurance companies don't want to control costs, and hospitals, obviously they want to charge kind of the highest price they can, that makes sense. I guess the thought process behind the price transparency is if we give people this information, can they use it? Not really, because they're not the customer. The problem with American healthcare is that the patient is not the customer. A customer is the person or business with the ability and willingness to pay for a product or service. In this scheme that we outlined before with the employer-based health insurance, we think that the patient should be the customer, but that's not the case because they're not the one able and willing to pay for the service. It's the third-party insurer that's the customer. And so we as the healthcare providers, although we're caring for the patients, our actual customer who we're gaining payment from is a business-to-business transaction with the third-party insurers. Last year, or about thereabouts, I was downtown filling a medication prescription to go abroad, and I was behind a family in line. And I heard the pharmacy technician tell the patient in front of me, you have two options today. You can pay out of pocket and pay $27, or we can bill your insurance and it'll be $92 today. And I scratched and thought, that's really interesting. And then the pharmacy technician kind of rebutted to the patient's questions about this and said, well, if you bill the insurance, obviously it goes towards your deductible. So that's where the factor might be that you'd want to pay the higher amount. But this outlines an interesting point. The first choice is such a simple one. You pay the pharmacy, they give you the meds, simple, not much complexity there, it's cheap. But when you involve, as some people call it, the medical industrial complex with the employer and the third-party insurer and all the work to submit the claims and adjudicate the claims and pay the reimbursement and do all the things in the administrative burden, it makes sense that it'd be a lot higher. Estimates are that this is about 25% of all healthcare spending is just making the system and the logistics run. I haven't even gotten into pharmacy benefit managers or the complexities. That's a topic for an entirely different discussion. New companies are coming up to kind of take advantage of this fact. And so one of them you've probably heard of by now is Cost Plus Drugs, supported by Mark Cuban, the kind of Shark Tank famous Dallas Mavericks owner. And this is super simple. They're making and selling generic drugs directly to patients and cutting out all the middle people for pennies on the dollar. There are examples here, lisinopril, $5 instead of $33. So then the next thought I had was, what if we can do that on the hospital and physician and clinic side of things? And we started to go to work. Huge thanks to Jake Morey, Rick Winters, Aidan Mullen, and Derek Jones for our work together on looking at payer type and emergency department visits. And we took some of this price transparency data and looked at level 5 visits, multiple visits, but I'm highlighting level 5 here, that indeed showed that cash prices, when they were available, were lower than private insurance, at least the median was, still higher than Medicare and Medicaid. But if you asked for a cash price, you'd likely be able to pay a lower price even than your insurance, who has strong negotiating power, would be able to do. And we have this information, we have this data. In some of our health system sites, we were recently, I'm not sure if it's still ongoing, but had listed the prices of each study that were transparently listed right there in the quick lists. We have the dollar signs here in Rochester that kind of are relative amounts, but we know what the costs are. We also know, thanks again to more work by Jake, I wasn't involved in this one, but Drs. Morey, Winters, and Jones also did a publication on using AI to predict billing code levels using our notes and the orders during a visit. And they showed that they were able to very accurately predict what a visit was going to bill at. So we hypothesized, what if we took this real-time price transparency that we're developing? We provide payment options, including the risks and benefits to each, and allow payment at the point of care, just like at the pharmacy for that patient that had the option to pay cash now or pay some mysterious higher cost down the road. We could eliminate all the so-called medical industrial complex from the mechanism and make care simple again. We went down this road, and I worked with business development and revenue model innovation and contracting and payer relations. It's incredible working here because we have such a vast array of staff and teams who are experts in each of these areas. And although there was initial excitement, it became pretty quickly clear that regulations wouldn't allow us to do this. Pharmacies are excluded from the regulations, and that's why we're able to do it in the pharmacies. But if a patient has insurance, we have to bill insurance, unless they ask us specifically saying that they don't want us to bill their insurance. And then we have to have them sign a form saying that they didn't want that. The catch is we can't tell them that they have the option to pay cash, even though the option always exists. The Institute of Healthcare Improvement under Don Berwick many years ago had, as it's the triple aim became famous from them. It was an aim to improve outcomes while reducing costs and improving experience in healthcare. And they've now developed, the quadruple aim involving provider experience and the quintuple aim with involving health equity. But the root of it's still this triple aim. When we look at our outcomes, we're all aware that our outcomes are a lot worse than a lot of other countries that have comparable economic development. Our life expectancy is 3 years lower than the OECD average. Our avoidable deaths per 100,000 people is much higher than average, 336 versus the rest of the groups, 150 to 200. So if our outcomes aren't great, what's causing that? Well, there can only be, kind of going back to engineering thought process. You've got your inputs, your processes, and your outputs. Our processes are, I feel, very efficient in the United States. A number of practicing physicians per 1,000 people in the United States is only 2.6. We're among the lowest among the OECD. The average is 3.7. So each physician is caring for a larger number of patients. But the amount people go to the doctor is much less here in the States as well, with approximately 4 visits per patient per year in the United States. Our hospital stays are short at 4.8 days on average. And the total number of hospital beds per 1,000 person population is 2.8. We run our hospitals very efficiently at very high capacity. We screen for a lot of cancers and disease. And we do a lot of imaging and we do a lot of procedures really efficiently, especially given our low rate of physicians to the patient population and low number of visits overall. So if our processes are good, and the processes I feel are where we focus a lot of our time, always improving our processes of what we're doing day in and day out. And we're good at that. But the inputs, let's look there. Adults in the US are most likely to have multiple chronic conditions of any OECD country at 30.4%. And the obesity rate is nearly double the OECD average. We're now at almost 43% of the US population is obese. And that's rising in every single state. So since 2011, this is a chart of every state and how much it's gone from the pink dot in 2011 to the blue or purple dot in 2021. Vast, rapid increases across the board. This is the data since the 1960s, showing the obesity rate, again, 43% today, and the severe obesity rate also rising commensurately. Mental health is also a massive and growing problem, especially among our younger populations. It's growing overall. The rates of mental illness are growing, but growing faster in the age 26 to 49 population, and even faster still in the 18 to 25 age range. Now, nearly 35%, more than 1 in 3 people in that age group have mental illness. And I think the rate's even more alarming and the increase even more steep in, the rates of obesity in 2 to 5-year-olds now is up in the 15% range. By 19 years old, we're approaching 1 in 4 patients with obesity. This is ages 2 to 19 years old, 6.1% severely obese, again, 20% obese, and 16% overweight. And again, showing my statement before of just how much the growth into adolescence of obesity overall. But obesity itself, even though it's an input into our system, it's an output of another. And the inputs into the nutrition and care of our young ones is becoming, just like health insurance, more and more consolidated across the country, with the vast majority of brands being bought up by a small number of large companies who are controlling the food market. This is a market analysis of some of the largest sectors in the food industry. And you can see, for instance, that McDonald's has 15% market share in fast food, but going toward cold cereal, it's more like 50% or 40% of the market to General Mills. For soybean processing, you have only 4 huge players, of which Cargill is one, located here in Minnesota. So our outputs are suffering, our inputs are suffering. We're doing what we can as healthcare professionals to address these issues. And as you would expect from the incentives in the marketplace, we're developing drugs to help combat this. And so just recently in the New England Journal of Medicine, a study was published showing the effectiveness of liraglutide, one of the GLP-1 agonists, in children as young as 6 years old. And so now a subsequent Nature article addressed the ethical implications of this in our society. Are we going to start administering these medications with limited data about the long-term consequences to children at that age? Not to mention the associated cost of these medications at nearly $1,000 a month intended for long-term use. The incentives are clear for the pharmaceutical companies, also now for the insurance companies, as we understand, because they want the prices to go up too, just as we talked about before. I think this is a fascinating chart. It's about lobbying industries, which industries have the leading lobbying in the country. And pharmaceuticals and health products are, perhaps not surprisingly, the largest at $378 billion a year spent on lobbying. What's also interesting are hospitals and nursing homes are on this list as well as health services and HMOs. And at least a portion of the insurance business here, I anticipate, is health insurance. All of these combined, it's clear to see that a vast, potentially even majority of lobbying spend is done by some healthcare or healthcare adjacent agency. This is oil and gas by comparison. Seems like a cottage industry in comparison. This is another depiction of all the different verticals and the different players in the space, all of who really at the end of the day are set to benefit from prices going up, from the increased consumption of goods and services needed in the healthcare space. How do you feel about all this? Is it overwhelming? Is it disheartening? I think it's a little bit of both. And so that's why I really find inspiration and it's inspiration and perspective. And going back to my mentor, Clayton Christensen, who unfortunately passed away in 2020, but who was my mentor for a long period of time and was a prolific author, writing many of these great books. I recommend all of these highly, especially Innovator's Prescription and How Will You Measure Your Life? But I talked about this in my last Grand Rounds 3 years ago, but I want to kind of go over it again. And my biggest touch points from what I learned in working with him and why they inspire me of how we can actually address these seemingly complex and overwhelming issues. I want to discuss sustaining versus disruptive innovation. Sustaining innovation is the incremental improvements to existing products or services aimed at meeting the needs of current high-value customers. It's what we're doing on a daily basis, improving care, and doing what we're doing now. The disruptive innovation is building new technologies or business models that initially underperform in mainstream markets, but appeal to niche or price-sensitive customers and eventually overtake established solutions. In graphical format, you have a certain product performance on the y-axis, and over time, a customer's need will change, and their different customers have different needs. And our sustaining innovations are set to increase performance slowly over time. We improve efficiency, improve quality, and such. One example of that's US Steel, which was a big steel manufacturer and actually in the press now. They worked for a long time increasing the quality of their steel products and chasing more and more profitable customers. At the low end of the steel market was rebar. used in construction, and they kind of let that business go over time. New competitors came into the space, namely Nucor, and they ran these little steel mini mills, and they would melt down steel and make rebar. And slowly over time, they increased the quality of their products and met the needs of more and more customers. And US Steel eventually was disrupted out of a stronghold position in the marketplace. As incumbents focus on improving their products and services for their most demanding customers, and usually most profitable ones, they exceed the needs of some segments and ignore the needs of others. And that's what happened in US Steel's case. And that's happened again and again across industries. Digital Equipment Corporation was a big mainframe computer. Compaq came about. Most people couldn't use a PC in the business space because they weren't powerful enough. But over time, they became good enough for most cases. And then Digital Equipment Corporation was left products they couldn't sell. Blockbuster was a company that probably most of us used back in the day. You'd go to a local Blockbuster location, rent your video, take it home, and then return it. Netflix started as a totally different market. They started with renting you DVDs that they would send you by mail to keep it as long as you wanted. And then when you wanted, you just send it back in and they'd send you another one in your queue. It created a whole new market. And Blockbuster could have easily started this business, but they didn't. And so the question is, why don't companies disrupt themselves? Kodak camera invented the digital camera, which is lost on a lot of people, but they put it on a shelf and didn't do anything about it because it wasn't in line with their market dominant strategy of selling film. They didn't realize that this was a whole new market opportunity and a new way of thinking about photography and what the customer might actually do with cameras differently. So companies like Kodak and Blockbuster and Digital Equipment Corporation and US Steel, they have a competitive advantage in a certain field. That's how they got so big. And they developed all these resources and processes and priorities to do that. And that just creates an enormous amount of momentum down a certain road. And changing that momentum is hard. It's like a gravitational field of a planet. Trying to get a new idea out of that gravitational field is really challenging. But Netflix is one of these studies that actually did it. So in, I think, 2011 or 12, they made a shift for this DVD by mail business, recognizing that streaming was going to be the future. And they bet the farm. The stock price plummeted. People thought they were crazy. They were shutting down their DVD by mail business and they were going to go all streaming. People thought they were nuts to take this great cash flowing business and go into a new field, an unknown. We all know how they turned out. We probably all have had Netflix subscriptions. So we as Mayo Clinic and as healthcare providers are here doing our sustaining innovation thing. We're addressing the needs of our current patients and customers, and we tend to focus on higher and higher ends of the market. And we see throughout the healthcare space, not just Mayo Clinic, a focus on procedure-heavy specialties and doing more with a real overlook of the primary care space and of basic preventative health measures. And again, as I was alluding to before, all the incentives are for that in the marketplace. So I want us to think, are we the US Steel? And what's the rebar going on in healthcare today? And what's the streaming alternative or potential disruptive future of healthcare? Companies fail because they continue to focus on core customers that may not need or want new or disruptive things. We continue to chase profit margins for existing high margin customers when disruptive innovations might offer lower margins that make them less attractive to us, a la primary care. And like I said before, there's organizational momentum that just says it's really hard to pivot toward doing something different. The outcome typically is that startups or smaller companies typically adopt some disruptive strategy. They refine it and they gradually gain market share. And over time, these disruptive innovations become good enough for mainstream customers and they overtake the incumbents, like Netflix taking over Blockbuster. So how do we overcome this innovator's dilemma? It's really what we're experiencing today in healthcare. Even if you step back all the way to the industry level, we feel the patient's pain from these high bills. We experience the difficulty in establishing care. We've all seen patients who come to the emergency department because they can't get care elsewhere. We've seen the patients who drive halfway across the country because they're fed up and they have no answers. To overcome these systemic dilemmas, I continue to feel that we have to separate teams. We have to create independent divisions that focus on these disruptive innovations without being tied to the core business model with our competitive advantage that continues to absorb back in anything that's close to it. We have to experiment and embrace small-scale experiments with new technologies and business models, even if just to learn and adapt them. We have to pay attention to customer needs and ask our patients, what is it that's working and not working for them? And what have they experienced elsewhere in the marketplace? We also have to take a long-term stance. We might have to accept lower short-term profit and financial rewards for long-term success in new markets. I love working here at Mayo because it's such an entrepreneurial spirit that got us here. If you look at the Sisters of St. Francis and the Mayo brothers, they were truly entrepreneurs of their age. And they left a legacy that really is an organization and culture that, in my mind, is one of the greatest achievements in American business and organizational history, not to mention the impact that we've had on the world and on healthcare. So even though my lessons over the last couple of years in trying to eliminate the immense amount of administrative complexity and drag on our healthcare system, I still recognize there's enormous opportunity there, and we're continuing to do things here at Mayo along those lines with business development and the employee entrepreneurship program. And I'm just really grateful for everyone in the department for all their support through all of this. Thank you so much for joining today. I appreciate your attention.
John, thank you so much. That was great.
The Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.